And TTAC is a partnership between the New York Center for Child Development, NYCCD, and the McSilver Institute on Poverty Policy and Research. The New York Center for Child Development has been a major provider of early childhood mental health services in New York. And we have expertise both in forming policy and supporting the field of early childhood mental health through both training and direct practice. Our partner, NYU McSilver Institute for Poverty Policy and Research, houses PeerTAC and the Community and Managed Care Technical Assistance Center, which offer clinic, business, and system transformation support statewide to all behavioral health providers. TTAC is tasked with building the capacity and competencies of mental health and early childhood professionals across child serving systems through ongoing training and technical assistance. And for those who may not be familiar, I just wanted to show you a screenshot of our website and let you know that all of our webinars are archived here. You can go on there and click on training and you will get both the recording as well as the PowerPoint. So we just want people to be familiar with the resources. And lastly, I just wanted to let people know about two learning modules that we just released, the infant and early childhood mental health. And the first module in the series is the impact of early childhood adversity, which is really an overview. And the second is nurturing resilience, supporting infant and early childhood mental health. CEUs are available and they're great introductory webinars for people who want to understand more about infant and early childhood mental health. So it's now my pleasure to turn it over to Dr. Gil Foley, who's the clinical co-director of TTAC, and have him introduce our speaker. So thanks for joining us today.
Thank you, Evelyn, and welcome colleagues to what I think will be a very exciting talk today, and one really of addressing a often under-identified and underserved population. Our speaker today is Dr. Juliette Vogel. She's a developmental psychologist and child and family clinical psychologist who is an associate professor at Zucker School of Medicine at Hofstra Northwell. She has considerable experience with both developmental disabilities and child trauma. She has led trauma-related intervention, education, and research projects. She's worked on preschool evaluation and intervention teams and is a rostered therapist. Co-developer of the National Rehabilitation Center for Supportive Recovery Medical Center. Dr. Vogel received her PhD in developmental psychology from Harvard University and also completed a clinical psychology respecialization at Michigan State University. And Dr. Vogel is a respected colleague of mine. We had the opportunity to work together probably more years than we'd like to admit, Juliette. Yes. Special needs program at Long Island Jewish Medical Center. So without further ado, Juliette, take over.
Thank you very much, Gil, and thank you for the opportunity to do this presentation. Please let me know if the sound breaks up because Gil, your voice did a moment ago. So hopefully I am still clear. And could I have the next slide? Okay, what I'm going to be presenting today is based on work that I've been doing for the STRIDE Center, the Center for Supporting Trauma Recovery for Youth with Developmental Disabilities at Long Island Jewish Medical Center. We are part of the National Child Traumatic Stress Network. It's a treatment, adaptation, and dissemination center specifically to address needs of children with developmental disabilities who experience trauma. And though NCTSN has been around since 2001 and has many resources, the STRIDE Center, when it started about 6 years ago, was the first center that focused on the needs of children with developmental disabilities. So we have some companion sites over the last year and a half. And so the goals are both to provide education on trauma needs of children with developmental disabilities and to tailor treatments. We've begun with older children and trauma-focused cognitive behavior therapy for a variety of reasons. but I'm very pleased that we can start also presenting information to you about the children up to age 6. Okay, next slide, please. I want to thank Peter D'Amico, who is the PI for the Stride Center and a very important colleague in supporting this work. And while I'll be presenting today, I've had 2 wonderful coaches of Joy Osofsky and Kay Connors, and I've learned a tremendous amount from children and families over the years. Next slide. So what is the plan? Some introduction regarding child trauma, then evidence for the co-occurrence of trauma and developmental delays and disabilities in early childhood. And I'm going to pause for just a moment and say that one of the issues for early childhood is we don't really know which children have a temporary delay and which ones are going to stay in a disability category. In many cases, that's not always true. There are children with a known genetic disorder. There are children with clear autism, children with a sensory disability. But in many cases, it is indeterminate in the early childhood period, which is both a source of anxiety for families and a source of hope and opportunity. I will talk briefly about some of the issues regarding being cautious about direction of causality, about an association between developmental delays and trauma experience. A little bit about the role for early intervention in preschool education, and then a little bit about what we are beginning to know about trauma treatment for these youngsters. Next slide, please. So the 0 to 5 definition of trauma for young children: exposure to a frightening or terrifying event or series of events that the infant or young child may experience directly. They may witness it as it occurs to others, or learn that it's occurred to a person significant in the infant's or young child's life. And that last one is important because of their being so dependent on it. Okay, next slide. Yes, you were right to go on. Okay, so some types of trauma and examples concerning young children. Accidents. Many years ago, I was asked to do a consultation to a preschool where a line of children with their teachers were crossing a street, which they did frequently, but a car came around the corner and hit a teacher and one of the students. They were injured, but fortunately they were okay. But the consultation was actually to the teachers and the parents about how they could talk to the children and help them process it. Disasters. After 9/11, meeting with parents who had had children in this age group and had had to figure out how to explain to their 2, 3, 4-year-olds about the death of a parent, or a child who has been in a house that was flooded and now is afraid of the bathtub. Frightening medical procedures. As I'll talk about later, there are many children in the preschool year who have such procedures. And I've done treatment for children of that sort. And my guess is in programs that you work with, there are children who've been through medical procedures. They're not that uncommon. Exposure to violence, community violence, domestic violence. I was commenting with Gil before we started about a little girl in the intervention program we both worked with who was language delayed and selectively mute, but she began sitting in her cubby when it was dismissal time. And that was our cue for finding out about the degree of arguing that was going on at home between the 2 parents. And we'll talk more as we go along about neglect and abuse. And events can be time limited, but very often even things that seem like they would be, like an accident or a disaster that's a flood and the flood goes away. But they can lead to a cascade of events that happen over time. Like, okay, but I have to move out of my house for a while. And that can be very disoriented. Or after an accident, there's a medical procedure. They can be things that are recurring or ongoing, such as many types of community violence, domestic violence, or maltreatment. Okay, next. This is from the Children's Bureau to say For victims of maltreatment, where do the most children fall in terms of age? Under a year is 25% of the youngsters. And then over the preschool years, it goes down, but it's still significant. And the under sixes have more than any of the older ages in terms of maltreatment reports. Okay, but where do developmental disabilities fit in? Next slide, please. First of all, we have some population studies. These are in the modern age ways people have of linking huge databases. And for example, in McLean's study and Spencer's study, they've taken about 20 years of birth records for their community. And they've managed to keep identifiers that would allow them to link to maltreatment databases and disability databases, but take out the individual names of the individuals and keep confidentiality. And overall, the results are higher rates of maltreatment for people with disabilities than for non-disabled children and adolescents. But there isn't a lot in these studies pulling out the younger children. About the one thing that one can see is what's in red here is some information about when did the first maltreatment report happen for these youngsters? And the answer is pretty young. In one study, the average age was between 4 and 5, both for with disabilities and without. In one of the early studies for Sullivan and Knudsen, if you were language delayed or had learning issues, the average age was in the preschool years. For youngsters with development with intellectual disability, it was evenly divided between preschool and elementary school. And if you control for high-risk demographic factors, the associations go down, but they don't disappear. Okay, next slide. There is a very interesting database, 2 studies that actually go beyond what is in these large studies and pull out information that includes screening evaluations of the children. There are 2 iterations of the National Survey of Child and Adolescent Well-Being. These are selected to be representative of the whole country. They include literally thousands of children. They oversampled infants and young children, and the children had screening assessments shortly after a child welfare investigation was completed, 18 months later, 36 months later, and in the first of the 2 studies, they were assessed once more at 5 to 6 years later. And the first study had one additional interview that didn't include an assessment at 1 year after baseline. Next slide. So you get information from the child welfare workers and the caregivers, and by far the majority of these youngsters were still at home with their parents. Some were in foster care, and the ones who were in foster care could be informal kinship foster care, informal kin foster care, or placement with an unrelated person. The screens for the children included the Bailey Neurodevelopmental Screener for infants, and I will not be talking about that today. A portion of the Battelle for children up to 4, and then the KBITS for cognitive screening, preschool language scale, and for adaptive behavior, the Vineland daily living skills. And there are different versions used for the 2 waves of testing because they happen at different times, but there were always this set of measures. Next slide, please. Okay, so to pull out children at high developmental risk, this is a large database, different people have analyzed it, but the one that is used most frequently and I think makes most sense is to say, okay, how many children were 2 standard deviations below, were in the lowest 2% on one of the 3 central areas, or 1.5 standard deviations down in 2 or more errors. Or they had an established medical condition like Down syndrome with a high risk of delay, whether or not the child was at the time of assessment actually showing the delay. Those were chosen because if you look at early intervention criteria for the states, this is typically the most stringent and most commonly used set of criteria. Next slide. So what do you find? 35% in the first of the 2 studies were at high developmental risk, and most of those were based on actual screening measures. If you go to 18-month follow-up, the proportion in a high-risk category actually increases. For the second study, it's very similar, 32% showed high developmental need at baseline. So we're dealing with almost 1/3 of the children in the preschool period who are referred to child welfare. Okay, next slide, please. Okay, so when you're dealing with the school age and adolescent population, you'll see lots of articles that talk about children with disabilities have much higher risk of being maltreated. And the problem is that often that's based on correlational data, and you really don't know the direction of causality. In some cases, it's clearer, such as issues of bullying. But when you deal with little ones, there are some chicken and egg sorts of problems. In what cases does the maltreatment lead to a delay? Or in what cases does the delay lead to maltreatment? Or in some situations, you may have environmental conditions, biological conditions that contribute to both. And you actually have articles that show some complicated pathways and varied pathways when neglect is involved. But one of the interesting pieces of data in the first of these 2 national studies was they looked at children who consistently had low scores over the period of the study, or at least over the first 36 months after reporting. And they found that the children who were most consistently in a low score group were children who also had very high environmental risks, such as higher degree of poverty, though this was generally a not wealthy sample, low education of the mother, or an impaired mother. So again, that speaks to, in that kind of situation, how much of this is biological, how much it is environmental, how much is all of this interacting. And that leads to the special issues associated with neglect. Next slide, please. Neglect is by far the most common type of maltreatment for infants, toddlers, and preschoolers. It can be lack of supervision, it can be lack of resources, but it is neglect. Severe neglect is associated with significant delays. There's a long history of evidence of children impaired as they are in depriving institutions. This goes back very early in the 20th century. There's a fascinating study by Skeels and Dye of children who were in an orphanage and were not doing very well. And so they sent them to the neighboring institution for what was then called the mentally retarded. And the kids were cared for by adult women who were considered retarded. And the kids did better because they were getting a lot of individual attention. But there's more systematic recent data from the Bucharest orphanage studies. These were children who were in large orphanages and do this in an ethical way. Okay. Are people still able to hear me? I'm getting some internet instability.
You faded out for just a moment, but you're back. Thank you.
Good. I think there's a thunderstorm starting is the problem. but let's hope I stay back. Okay, so what the studies like the Bucharest orphanage studies show is that the impact of severe neglect is more likely to be reversed if the child gets to a good environment by about age 2, and they're actually able to show sensitive periods that you shift around the degree of recovery depending on the domain of development. Okay, next slide. Then there's the issue of quasi-autism, that some of the youngsters with severe neglect show symptoms partially mirroring those of autism. For some youngsters, they do disappear over time. For some, they may have long-term consequences. And in the early intervention program, where Gil and I both worked a long time ago, we had a couple of these youngsters. I won't spend time now describing them in detail, but they were both youngsters who came in looking very self-directed and highly suspicious of autism. They still had delays after a year in the program, but they did not look nearly so much at risk as having autism. Okay, next slide. I want to not just stay with maltreatment. There are plenty of children with disabilities who have other kinds of traumas. One of the things that we know is that children with disabilities are at heightened risk for stressful medical experiences. They have higher rates of overall healthcare needs, higher rates of injury, more medical visits, more emergency room visits and hospitalizations. And in the telling of reasons for those visits, seizures are the most frequent one. So those are a major problem for a large number of young children with disabilities. I want to bring people's attention to one wonderful website. Boston Medical Center has what they call their autism-friendly initiative. And on that website, they have a gallery of social stories meant for children with autism, but I think appropriate for many preschool children, that in simple pictures explain very common medical procedures. In doing clinical work with a youngster who had both a developmental disability and many hospital visits, one of the things that was really important was to help the family prepare when a child did have an upcoming medical visit about what to expect. Okay, next, please. Okay, there are some very interesting opportunities, but challenges with early intervention Part C. And I would assume that most people are aware of what it is, but I'll review it very briefly. It's the part of the Individual with Disability Education Act that deals with children under the age of 36 months. And it provides assistance to states to have a comprehensive system of early intervention services for infants and toddlers and their families, which are supposed to be integrated across areas of care, which, as Peter and I talk about frequently for the older youngsters, the integration often doesn't happen for children with disabilities. So the states get to do their own definitions. I've given you earlier the most frequent ones for significant delay or diagnosed medical conditions. A few states also include children who have risk factors like environmental situations that might lead to delay. Since 2003 and 2004, child welfare and IDEA legislation has provided specific information about children with linking this to child welfare cases. That if a child in that age range has a substantiated maltreatment case, then there's supposed to be provisions and procedures for states receiving support for Part C to refer these children, all of these children, for of Part C. That doesn't mean they have to receive services, but they have to at least be offered the opportunity for an evaluation. Well, what happened before that was in place and what happens now? So let's look at the actual data. Next slide. Oh, actually, before we get to that, it offers an opportunity to expand services, at least for children who have substantiated maltreatment and delay, to get developmental treatments they actually need. There also are discussions of using Part C as a way to make trauma treatment more available, at least for the children with co-occurring delays. But when the state legislation allows it, the state system, also for the children who have high environmental risk. Okay, so let's look at what happened before that addition to the Part C legislation and what's happened since then. The first wave of the two studies that I've just talked about before happened before this legislation. And what you see is they were actually more likely to refer the children without high developmental need than those with. The caseworkers were not good at judging which youngsters had high developmental needs. That was done as separate assessment. And the children with unsubstantiated cases who are not covered under the legislation had at least as high developmental needs. So, we're served at that point. If you ask who had a plan, now that doesn't say how many were referred, but how many actually had an individual family service plan by a year after the investigation, we're under 20%, including under 20% of the children with the diagnosed developmental needs. Okay, well, the second of the two studies happened after the legislation. So we can have the next slide and see what happened by then. We're now 4 to 6 years after the new requirement. Referrals to Part C remained under 20%. And again, substantiated were higher than unsubstantiated. The referrals were unrelated to the assessed developmental needs, though they did have some relation to what the agencies thought were developmental needs. Okay. So there is some progress since then, but these are the only good studies that actually have developmental measures. So we don't have something like this currently. There actually is a third study in progress, but I've seen no data, and my guess it got somewhat delayed by the COVID era. That's aside. Let's see some progress. Next slide. Okay, so by 2014, there was a survey of state Part C coordinators. 61% said that there were systems in place that children were all, if they were in child welfare in this age range, they were directly referred to the Part C agencies for screening. 30% said the agencies were doing their own screens. And one needs to hope that these were systematic evidence-based screens. Nearly 2/3 were fairly confident or very confident that all of the children under 3 with substantiated child welfare cases were screened, but that means about 1/3 were not. And there are articles that do describe some of the efforts that have been done on a state-by-state basis, and a couple about model programs to actually integrate services. So there is some progress out there. I'm not an expert in the area of how much progress. Next. What are some of the challenges for the people who are actually working in the agencies? And there have been some interview and survey studies with professionals and families, foster families, that will describe what some of the challenges are. How do you handle practical situations? For example, a child who is in child welfare, maybe in foster care, with visitation with the parent. And I'm sure there are a lot of people in the audience who have had situations either as a child care worker or as a clinician where a child is acting up in childcare after a failed visitation, a visitation that didn't happen or a visitation that did not go well. And there were also comments in the interviews about people in early childhood education or intervention feeling they needed more training in how they might deal with highly stressed families. Okay, next. Linda Gilkerson and her colleagues have provided their vision of what trauma-informed early intervention services might look like. And it's a very interesting article that actually describes 2 model programs that do a lot of what they're talking about. Really building on early intervention values of a family-centered program, not simply a therapist going into the home and working with the child and the parent agreed to the plan, but the parent isn't really part of the plan. And also realizing the importance of addressing social and emotional needs. Some practical issues, trauma screening. And I'm going to tell a personal story that when I was taking really only some child parent psychotherapy trauma cases at a point early in COVID, I wasn't taking other early childhood cases, but I had figured out a way to do those via telehealth. And I needed those actually to finish rostering at that point. And there were 2 instances where I got calls from people who were looking for help around their child's behavior problem. And I explained I was very sorry. I was really only taking referrals that dealt with child trauma. And then people said, oh, but that fits. And they explained the trauma that had actually occurred. But if you don't ask, often you have no idea. Some practical considerations. Whoops, someone isn't getting sound. Evelyn and Gil, can you hear me?
Yes, fine. Yeah.
Okay.
Yes.
One of the things that Linda Gilkerson and her colleagues talk about in the article is what happens when you take a child who's just had trauma that's involved separation from parents, you bring them in for an assessment and the evaluator says, okay, parents need to wait in one room and I will take the child into the next room. You're not going to get very useful information about what you thought you were testing. You might get a lot of information about responses to trauma reminders. Dealing with the impact on the family. Maybe if the family is in child welfare, suspiciousness of agencies and what kinds of records are you keeping? Or being preoccupied at times because there is so much going on for a family in the midst of trauma. A traumatized child might be in a traumatized family. And they talk about the usefulness of creating not just consultation between specialists, but sometimes even co-treating in addition to trauma training and consultation. Okay, next slide, please. Okay, there are some useful resources that are not specifically related to children with disabilities, but that do at least talk about discussing the role of early care and education in addressing childhood trauma. So one that's a survey of programs, one that actually talks about it state by state. And so in the slides, you'll have an actual web link for the Early Childhood Technical Assistance Center. Okay, next slide, please. Let's move on to the issue of treatment. Now, there are no real clinical trials that I know of trauma treatment for children under the age of 6 or over the age of 6 who have developmental disabilities. There is a lot of work, though, that you can find on application of trauma-focused cognitive behavioral therapy for the children who are at a developmental level that they can benefit from it, which are typically the children with developmental levels, at least in the late preschool to school age year. And that may then need to think that the preschoolers with disabilities is probably not a good match. There is very little out there. There certainly is discussion of using parent-child interaction therapy, PCIT, with this age group. But while there's a literature on use of PCIT with kids with disabilities, and there are some literature on using it for child welfare cases, there's really not good integration that I found. But there are a few places where you can find integration, 2 that actually exist, 1 that's in progress. UC Davis has a brief program, PC Care, that is derived in many ways from PCIT. It's very brief. One of the reasons for that is they found a lot of their child welfare families couldn't tolerate long treatments. They're dyadic treatment programs for families with children 1 to 10 years. The focus is on improving parent-child relationship and behavior management. And their website talks a little bit more about which families this might be appropriate for. One of the things that intrigues me about this intervention, and you have to be trained by them in doing the intervention, but there is an appendix that specifically talks about issues and suggestions for working with children with either autism or intellectual disability. Issues such as thinking through that sometimes the symptoms that you think are one might be the other. For example, both kids with trauma, young children who've experienced trauma, and young children with these kinds of disabilities can show highly repetitive play. They can show reactions to specific kinds of stimuli that might be sensory, but they also might be triggered by reminders of a traumatic event. So there's a very interesting set one category or the other. And then there are some suggestions that I think a good early intervention specialist would think quite straightforward but important about such things as using visual supports and routines. Okay, the second one is something in progress. For those of you who are trauma specialists, you've probably heard about ARC. Attachment, regulation, and competence is a framework that's been used for youngsters who experience trauma to work with the youngsters to work with their caregiving environment. And within the ARC set of tools, there is a parent program called ARC Grow. One of the applications has been for substance abusing parents or parents who have a history of substance abuse to help them with their own regulation and receptivity to their children's needs. The person who developed ARC Grow also has a lot of experience working with ARC with youngsters who have significant developmental disabilities. And she's in the process of developing a version of ARC Grow for families who have a child with a developmental disability, preschool up through school age. I don't have the exact ages in front of me. I've seen the materials, though they're still under development. I think it has a lot of promise. And like PC Care, it is time limited. And of the evidence-based trauma-specific treatments, child-parent psychotherapy at least has significant case studies and discussion about application. So I'd like to turn now to talking a bit more about use of child-parent psychotherapy. So it's an evidence-based treatment. It's designed for children from birth through age 5 years. It's meant for children who've experienced one or more stressful events, and that experience has impacted one or more domains of functioning. It could be their behavior, it could be emotional reactions, could be relationships, it could be some developmental perturbations. Alicia Lieberman and Alicia Van Horn have a wonderful book, Psychotherapy with Infants and Young Children. Then there is a manual that's called Don't Hit My Mommy, and that certainly gives the child welfare thrust that a lot of CPP is based on, but it's not the only one. I will mention a third book that deals with death of a parent at an early age. It's unfortunately out of print, but it's, if you're dealing with a young child who's had a significant person die, it's well worth getting a used copy. Okay, so why use this one for children with developmental disabilities? Next slide, please. It's uniquely positioned for tailoring for disabilities. If you actually look at the history, Alicia Lieberman is very clear that this evolved from Selma Freiberg's infant parent psychotherapy, which is a dyadic therapy for infants and toddlers, but not going up to the 3 to 6-year-old age range. And it has been developed, I mean, CPP has a bit more focus on trauma than the original infant parent psychotherapy, but it's very interesting to look back at Freiberg's writing and see where the infant parent psychotherapy came from. It actually came from work she had done when she was asked to consult with a group of children who are congenitally blind. The initial group was straightforward consultation. Some were very young, some were older. Then she did meticulous research, but also intervention with children who were carefully selected as youngsters whose vision was at most limited to distinguishing between light and dark, but really no functional vision whatsoever, but didn't have known brain damage or other handicapping conditions. And she did a combination of exquisite observation of the children and then worked on parent guidance, how she could help the parents. And she was learning along with them, but help them relate to their children and help them figure out what the children needed to actually function. And that work actually was what then in its next iteration became infant parent psychotherapy, though at that point, there was more emphasis on the ghosts that the parents brought and their trauma histories, where in the initial work with the congenitally blind, the focus was on the children's disabilities. But that's in the history of this particular intervention. Now, there's not a lot to go by in the literature, but what's there is very rich. There's a series of articles in the journal Pragmatic Case Studies in Psychotherapy, where a group from a medical center near Los Angeles was able to, I mean, they've been doing child-parent psychotherapy with children with developmental delays, with children with medical complications. They're in a very well-positioned setting. This is in a medical center, and it's also in a center that has a LEND center, leadership education in for individuals with neurodiversity. So they had a lot of expertise. both on medical issues and on developmental disability issues. There is a commentary paper by some of the primary developers and trainers in CPP, and there is then a discussion by the people who presented 2 cases. But first, a little bit about what child parent psychotherapy actually does, and then we'll look at Harley's cases. Next slide. It's a dyadic treatment of the child together with the caregiver. The assumption is that the attachment relationship is a key resource for young children in their ability to deal with stressful events. And then that becomes a key for trauma recovery. As a treatment, it draws on multiple theoretical orientations: psychodynamic, developmental information, what we know in trauma research, what we know about social learning and cognitive behavioral approaches. So it draws on all of those, but it really is embedded in looking from the perspective of the attachment relationship as a central healing possibility, but also when it's not working well as something that hinders recovery. It has a great deal of emphasis on looking at the social and cultural context, respecting the culture of the family, and saying when you're dealing with high need families, sometimes it's important to provide practical assistance with problems of daily living, issues critical to family functioning, if you're going to be able to address the trauma-related needs. Next slide, please. So the treatment itself has 3 phases: a foundation phase, which involves assessment and engagement. And it's key that you have to form a working alliance with the caregiver, or none of the rest of it is going to work. Clearly, you're going to be assessing what the child's issues are, what the child's functioning is. You're going to be assessing how the child and the caregiver or caregivers function together. And then what are the factors that might be influencing that functioning? That might be the functioning of the caregiver. It might be the trauma background of the caregiver that is getting in the way or facilitating the parent's ability to respond to the child. Selma Freiberg talked about ghosts in the nursery, but Alicia Lieberman also talks about angels in the nursery, the internalized images that parents have that help them with what they need to do. And then again, getting to the problems of daily living, impacting caregiving and well-being. And we'll get to that for developmental disabilities in a moment. Then the core intervention. These are primarily play-based sessions of the parent or parents and the child, and you're trying to facilitate understanding between the 2 of them, helping the caregiver support the child. For the pre-verbal child or even young children, you may speak for the child. You may help the parent to think about what the child's behavior might be saying about the child's fears, about the child's concerns, about the child's preferences. In doing that, you are providing some parent guidance, but particularly as children get older or as you're dealing with more sensitive issues, there may need
You just froze, so let's wait a second.
Can you hear me now, Evelyn? Hello?
Yes.
Okay.
It was about 30 seconds, Juliet.
Okay. And there does seem to be a thunderstorm coming and going. Okay. So going back a little bit, that you're dealing with parent guidance, sometimes in front of the child, but as one figures of what needs to be talked about, when I do CPP, I do a fair number of individual parent guidance sessions as well. And I think parent guidance needs to be understood. It's not didactic teaching, but it is sharing of information and it's problem solving together. And if one goes back to the original work by Freiberg, there's some very interesting discussion of how she developed that concept of parent guidance and what she really means by it. I think it's a little bit more complicated than it seems on the surface. Again, often this issue of coordination, in terms of addressing trauma, it depends on the issues, it depends on the child and circumstances. So I've done full trauma narratives, not in words, but in play, with a 3.5-year-old who did happen to have autism. But I've also worked with children where there never was a real trauma full narrative. So that's something that varies by the case. You're certainly not going to do it for a delayed infant. And I'll give you a little bit of case material about that from Harley's work in a moment. And then finally, something that marks saying a good goodbye. Okay, next slide. There are 5 clinical studies. And when people have looked to see what happened about children with delays, they either were systematically excluded or there may have been some, but they certainly weren't looked at separately. But there is substantial flexibility in the actual activities. It does require a time commitment. Weekly sessions over a period that can be as long as a year, though it can be quite a bit shorter if the case will allow it. And this is a treatment that can be in the clinic or in the home. And as I've learned in the past few years, you can do something that's neither of those, but rather it actually can be done by telehealth. But there are some caveats there. If the parent can actually help you set up a play situation at home, then you do have the benefits of seeing what's going on at home, but also being able to work with facilitating care. Not great sometimes with the sound quality, but it really can be done. Okay, next. Okay, so let's talk about some actual children. And one of the reasons that I like Harley's paper is that she talks about 2 very specific cases where this was used. The first one, and I'm realizing the name is not in the vignettes, and I'll repeat the vignettes at the top of each of these 2 slides. James was a 14-month-old who was developing normally. He was in a family of undocumented immigrants. Spanish was their first language. He had to have cardiac surgery. The surgery seemed to go well. It was 11 months. Then when he went home, he had a stroke. He had multiple seizures, and he lost much of this developmental progress. This was a high poverty family with a very small space, including both parents, 3 older children. And by the time this was done, the nurse who came in to do much of the care for this very disabled 14-month-old child. And so the child parent psychotherapist, who was working in a clinical program as a postdoc based in a large medical center, became the clinician to work with this family. Second, same clinic, but very different setting. This was a domestic violence case. In this case, a child had been diagnosed at a young age as having autism, but never had received any services for autism. Parents, again, were immigrants, but In this case, they were documented. There was a history of domestic violence by both parents to each other. The child had initially lived with both parents, then for a period with the mother, and then the father got told, you're going to take this child or he'll be put in foster care. So at that point, at the time of treatment, he was living with his father, who had exposed the child to domestic violence, both parents had, and the father's sister. So what do both cases involve? They helped parents with their own reactions. In the medical trauma case, the mother initially left almost all of the care to the visiting nurse and really seemed very depressed about her child's condition, minimal interaction with her child. In the domestic violence case, the father had lots of guilt about his earlier role, and that made it very hard for him to set any limits with his son. So in both cases, the clinician very sensitively and gradually worked on helping the parent understand who their child was, both trauma and development. And for example, in the medical trauma case, it wasn't just distressing when the mom had to take the baby for periodic medical visits, but the mom herself. I mean, the mom was upset, and as she got to watch, she could see the child's upset when they had to go to the hospital and have appointments. In both cases, developing a sense of hope. And as we'll see in the next page, some of that sense of hope involved referring for services that would help, but we're not back to the first page for a moment. Okay. Trying to work directly on the parent-child interaction. So for example, with the baby, pointing out how the child did react to the mother's presence when the mother actually could be present for him. And I don't mean physically present, but actually interacting with him so that he got a sense of response back from her. Okay, now to the next one. Okay, so what made this work? There was interdisciplinary consultation for better understanding about child development and development issues for the child, and support on how to facilitate developmentally appropriate interactions. Actually, in the 14-month-old case, there was not just a referral to early intervention, but a discussion of how once the early intervention started, the therapist was present for many of the early intervention sessions and could help the interventionist know some about the child's issues at the same time as the therapist was learning about what the interventionist was doing. In the case of the child with autism, he could be very dysregulated in session. And one of the experts on how to help him not be so dysregulated was his occupational therapist. So over time, they actually co-led some sessions together. In both of the cases, they were working on honoring cultural factors, and it helped that this was actually a bilingual therapist, and assisting them with access to resources, both in terms of the child's disability and in terms of some general needs of the family. Okay, next slide. And you know what, there is one hidden slide that I didn't think we were going to have time for, but we might. If you, I don't know if you can show the one that's before this one, but is hidden. No. Okay, no, that's all right. Just stay here. And there was one actually, there is a set of commentary by Chandra Grosh-Ippen and Alicia Lieberman and Carmen Rosa Nerona, and I can say a little bit of what they've said, but I think what's critical here are some of the points that both Harley made in her original article and then Marion Williams, who is the senior person in that group, about what were general principles for them. The therapeutic assessment was also an intervention. It was helping the family see themselves as well as helping the therapist see the family. It's not just about grief work, though certainly in the slide that I don't have visible, they talk about that is a big issue for some families where there is a disability, but also supporting what is resilient about the family, supporting what they are doing correctly. The access to resources, they could be educational resources, they could be disability services. In trauma work with individuals with disabilities, there's an important caveat of what the goal is. It's to resume the optimal developmental trajectory for that child. So when we talk about trauma recovery for a child with a developmental disability of any age, it's not to get them onto a developmental trajectory they've never been on, but to get them onto their own developmental trajectory from which they have been somehow sidetracked. And one of the things that Harley and Williams raised that I think is an important consideration is when you have a child who is developmentally at a preschool level, but chronologically older, this still may be an important intervention. Okay, next slide, please. Okay. For the last 2 years, I've been listening to my colleagues and working with them as they've worked on tailoring trauma-focused cognitive behavior therapy for older children with disabilities. There are many similarities, but there are also some important differences. So how do you tailor to the child's developmental level while honoring the general principles of the therapy? And that's a little bit easier for an intervention. Actually, both of these interventions, you're supposed to choose materials and activities that are at the developmental level of the child that you're dealing with. For both, pay a lot of attention to language that you use, simple language, and nonverbal supports, because language may not do all of what you need. Structure and routine is important in any therapy. It is particularly important both for trauma and when you layer trauma and disability. Caregivers are key. They typically know the child much better than the therapist does. And just as TFCBT with children with delays uses the caregiver in the session much of the time, that's true in child-parent psychotherapy, but it's even more true and it's more basic to the intervention. The need to coordinate with multiple systems and taking cultural context into account. And this is cultural context, not just about beliefs about therapy, but also about beliefs about disabilities, about who's responsible for childcare, who's responsible for dealing with disabilities. When you move to the work for the little ones, there are also some differences. The central role of attachment, the belief that that is the most important buffer that you can give and the most important road for the child to recover from the trauma aspect of what's going on. So if you're going to work on attachment, you need to not only support the child, but support the parent as well. Typically in TFCBT, a trauma narrative is central, though there are some data that if you do all the components but the narrative, for some families that can give you a lot of mileage as well. And child-parent psychotherapy can be used when the child is pre-verbal or non-verbal. So that extends the range, as in the 14-month-old who was one of Harley's cases. Okay, next slide. These are some concluding thoughts. This is rewarding but challenging work. And I think I'm going to go down to the last point and then come back to the other. As in any trauma work, it's very important to have support of others when you're doing that work and to think about self-care, such as how many trauma cases can you deal with at one point? Okay. The helpfulness of interdisciplinary teams, or as some of the work Gil has done, transdisciplinary work, where you actually have different members of a team with different professions learning from and then applying some of the principles from the other team members. That's wonderful when it's available. I think it's not an accident that Harley and Williams cases came from a medical center where it was a medical center, so you had integration into the medical parts of treatment, and it was a teaching hospital, and it was a LEND center with expertise in developmental disabilities. One of the problems is we want a workforce that's not always going to be so richly connected. So finding ways for people to get training and consultation. For trauma therapists on development, developmental disabilities, and disability services. One of the experiences I've had is I've had 2 trauma cases of young children, one 3-year-old, one 5-year-old, who arrived in my office for treatment for trauma. And I noticed in the first session that the child was reversing pronouns like I and you. And the part of me that's trained as a developmental psychologist said, this is a very important sign. Let's start thinking about autism. And in both cases, eventually that was an additional diagnosis. These were educated parents, but nobody had actually made that diagnosis. It was a process over a period of months of talking back and forth. Was this something to evaluate? How would we know if it was something to evaluate? But if you don't have that training on development and on developmental disabilities, then you need to be able to talk to somebody who does. And even for the preschool trauma people, they may not have the degree of training of disabilities or even the depth of training of normal development that I'm lucky enough to have, but then you need consultants who have that degree of training who can extend eyes and ears. And you also need to know about what services are available. Okay, for developmental interventionists, how do you know about trauma issues and trauma-informed practice? Be aware of trauma triggers. Be aware of family sensitivities. And for both groups, to be able to work with medical specialists and get information, share information, know how to collaborate with them. And again, as in any trauma work, the importance of getting support, both about the work you're doing as technical work, but also about dealing with what you take home at the end of the day or don't take home, about some of the pain that you've seen, but also about some of what can be accomplished. Okay, thank you very much. And I think, Gil, are you monitoring questions?
I am. And thank you, Juliet. It really was a beautifully constructed, informative, and scholarly presentation. And we don't have any written in questions, but maybe we can open it up to discussion. And if I may be so bold as to take the lead, I think your presentation speaks to, unfortunately, a continuing problem in our system. And that is that it is a bifurcated schismatic system where we have early intervention services on this side and mental health services on that side. And there really needs to be much more of an integration of these services. I did an edited book with Jane Hockman in 2006 called Mental Health and Early Intervention. It didn't have a trauma focus, but looking at the absolute need to bring these two specializations together. And I think your presentation illuminates that that is a continuing need. And not only at the level of service, but also at the level of professional preparation, as I think you suggest. And secondly, I just want to share a little bit of some work we actually did at New York Center with the aid of a project, with the aid of a city grant, where we actually treated 13 preschoolers who had a developmental disability, a good number with autism and with trauma. And we had a wonderful team that included, we used DIR, developmental individual relationship-based treatment, combined with CPP. And we didn't have a control group, but we really got significant changes on the CBCL, statistically significant, pretty large effect sizes. And some of that work did involve co-treatment that you talked about. And, you know, at the time, I think we thought that was kind of a radical and maybe inefficient thing to do. But as you suggest, I think sometimes it can be such a powerful intervention to bring these kinds of specialists together. And I think that research needs to be published, Evelyn, because I think it was really at the forefront. So I just wanted to jump in and start, and maybe this will, involve some discussion from participants.
Yeah. Gil, I absolutely agree. There is so little out there that anything that you can get published, and the silos, I didn't actually put in Peter's silo slide, but it is so dramatic for the older youngsters. There's actually a New York City study where they were trying to look at where do you send an adolescent who has autism and presents to the ER as potentially suicidal. So they went to the OMH clinics, and they went to the OPWDD clinics, and the OPWDD clinics in a few cases said, yeah, we could treat this kid for his or her depression. Or they said in a few cases, if they actually have state OPWDD services, which is a much smaller group, then we could treat them. But really, you should be sending them to mental health. Mental health primarily said, they belong in the OPWDD clinics. We don't know, we don't speak autism.
Right.
And so they're lost in the cracks between the two silos. So I think that at least the part C does give a theoretical for the maltreated youngsters, with the caveat that it has to be a substantiated case, not just one where you suspect a lot is going on, but it was never fully substantiated. So for those kids, there is a little bit of movement, and there is legislation that says you should do it. But that doesn't mean that people know how to do it. There are a few articles. I mean, I think that Linda Gilkerson's papers are beautiful. There are more that talk about integrating the mental health and education than talk about, and what do you do when there's a developmental disability involved as well? So it's resource intensive, but I think that's really a question of how do you figure out in this day and age ways to make training available and to make at least consultation available.
Absolutely. And even here, I mean, there's certainly, this has been acknowledged, but we know that even though, of course, social emotional is a part of early intervention and part of the 5 domains, it still is underrepresented in terms of mandates. And actually, Evelyn Blank was a leader in this to bring together a committee several years ago to look at mental health and early intervention, social, emotional. And what came out of was a guidance document that involved both EI and mental health individuals, a guidance document on mental health and early intervention. But we still need, obviously, we need more work. We do have some questions coming in now. So let me present those to you, Juliet. Are there connections or opportunities between CPP and parent coaching models like Circle of Security?
You know, I have to be straightforward. I don't know Circle of Security. I hear things about it that I respect. I think Joy Osofsky, who's been one of my consultants on child parent psychotherapy, has done some to bring them together. What I'm currently doing is I have a family who happens not to be a developmentally disabled child, but a wonderful youngster, wonderful mom. Mom's got lots of ghosts in her background. And since Christine Kinneberg has been generous enough to let me see the ARC Grow material, she's going to let me supplement what I'm doing with the child, with dealing with the mother on some self-regulation things that then shade into how she works to help regulate her child. So yes, I am playing with something right now that combines those two things. I will say that this particular mom also has her own individual therapist, and I'm trying to be respectful that I'm not working in the individual therapist domain, but rather those parts of a complex trauma history that impacts on parenthood.
Yes, great. We have another question, Juliet. What would you suggest for a 5-year-old who has had trauma and seems to be doing better without one of the parents who was a substance user who no longer resides in the home?
I think the problem there is complicated. In other words, the parent doesn't reside in the home, but is there a plan for involvement with the parent? And if so, then how do you help have protected time, keep the child safe, and also allow some kind of connection in a way that allows them to build a relationship? I mean, I can tell you that having had some foster care cases, these have to be ones where you have two willing partners.
Good
And
point.
it's not something, again, that I have a lot of personal experience with, but I know that there are people who do the work. It just has to be set up carefully. That makes
Another
sense.
another question that came in. I appreciate your comments about the impact of parental trauma on how they are able to parent and connect with their child. What can you say about parents with potentially undiagnosed ID or mental health condition? When there is a need to connect parents with their own mental health care, how do you deal with that, especially when parents do not have insurance?
What?
So
It's a two-part.
yes.
And, you know, the second part, I think I'm going to take first.
Okay.
Because what do you do when you know the resources should exist and they don't exist? And, you know, it's sort of, in this day and age, doing the networking you can to try to pull rabbits out of hats. There are cases that I used to say, I would never send this case to a university training clinic. And now I say, you know, a university training clinic with a sliding fee scale may be the best option I can have, and better than some community agencies that crank people through without really having time to do the work. So that's one part of it. What you do with the parent's own limitations, diagnosed or undiagnosed, you handle it with care.
Yes, yes. Well
Uh,
put. And yes, careful clinical judgment. Yes.
yeah, sometimes you can urge people towards treatment. Sometimes, I mean, I had one parent where I realized over time I had to provide a kind of structure that the parent simply was not capable of providing. And so at least for the point of the session, we did what we could and then worked with the other parts of the system to keep things as shored up as we could.
Very good. This one is an interesting one. We're running out of time, but I'm so happy to see people are writing in. Working within a state and early intervention Part C is a full entitlement, but trauma therapy within that system is not. How do we as an EHS provider advocate within Part C in the service if the service doesn't exist? Who can address it?
So I'm not an expert on how you deal with state policy, but I would recommend going and looking at writing by people like Linda Gilkerson and, right, I think I'm blocking on the name, I think it's Barrett, but there are, and then there is in the materials that I sent a technical assistance on early intervention that has a website, and I gave the web link, that talks about what is available state by state in integrating early childhood mental health and Part C. So I'd say those are the experts. I am not, but at least my philosophy is if I'm not an expert, give you a couple of names of people who might know some answers.
And there is one question here that I think is very relevant, just in general. Do you know any specific agencies, clinics in New York City, Brooklyn, that provide CPP or TFCBT for children and adolescents with autism? And really, this is what TTAC is about. We've provided a great deal of training to the agencies. There's agency in each borough, ECTCs that have received CPP training. And we can probably let you know which agencies those are, and they are a resource, particularly for children 5 and under, which has really been the whole thrust of TTAC. I think we're just about at time. I don't know if there's any. There are 2 more questions, and very good ones, but I don't know if we have time. One has to do with classroom, and so maybe I will just field that one. I'm thinking about a 3-year-old in a classroom that I support who has been in foster care since birth with a wonderful member of the center staff. Whenever the child has scheduled visits with his biological family, he comes back appearing agitated and dysregulating. Other than supporting him with strategies for self-regulation and giving him additional positive attention and reassurance and joining in his activities, are there any other recommendations for simple strategies for the family and the teaching team?
I think that's where the coordination issues come into play. That what is going on in the way visitation is structured, in the theory of how the integration of early childhood work and child welfare is supposed to work in the documents I've been reviewing. If there really were integration, the child welfare people would be thinking about how you structure the visitation. That's more often the exception than the rule. But it's again, it's aspirational. It exists in small measure in small locations.
Yes. I would also say, there's an increasing emphasis on mental health consultation to early care and education. And this is also a possibility if you do have a mental health consultant in your preschool program, that they can really help make some of this bridging between the therapeutic work and the educational work.
Yeah, thank you, Gil.
Yes.
So I just wanted to thank you, Dr. Vogel. This was a really, really informative and very relevant presentation. So people keep asking, will it be posted? Yes, it will be posted on our website in a few days, along with the recording and the PowerPoint. And if there are other resources you want to add, we can also post those. Thank you, Dr. Foley. And I wanted to encourage everybody to please go in and fill out the evaluation. We very much rely on it and like the feedback. So thank you so much.
Thank you,
It's a
Julia.
pleasure.
Bye.